Good afternoon, everyone, and thanks so much for joining in. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds, which is entitled Updates on Emerging Viruses, COVID-19, MPX, and Enterovirus, including polio. Just a reminder that this educational series is generously sponsored by a partnership between California Medical Association and the California Health and Human Services Agency. Next slide, please. Here are our speakers' disclosures. Next slide, please. And this is our agenda for today, which I'll go into in a moment. Next slide, please. And finally, just reminding you that we do provide CME for this series. Just make sure that you complete the survey that we'll send you after the completion of the webinar, attest to attendance, and then we will send out your certificates. Next slide, please. So, though it may not feel like it, COVID-19 still remains on our radar. Definitely feels like it to some folks, those in the hospital. But other infectious diseases are also causing new or unusual symptoms and warrant our attention. Today, I am so excited to be bringing you a trio of clinician detectives. Doctors Carol Glazer, Dr. Keith Van Haren, and Brittany Martin are here with us today. These three will tell us a fascinating story about some emerging enterovirus activity that's causing severe respiratory illness and a neurologic syndrome known as acute flaccid myelitis. But before we hear this story, I'd like to welcome back Dr. Erica Pan, our California State epidemiologist and the Deputy Director of California Department of Public Health, to bring us up to speed on COVID-19 and the other respiratory viruses that have kept our clinics and hospitals incredibly busy this fall and early winter. Just as a teaser, I will say that our presentation in January will give us lots more information about the so-called triple-demic with the RSV, flu, and COVID, so please do tune in then. But with no more ado, Erica, let us know what's going on.
Great, thank you so much, Kim. Good afternoon, everybody. Thanks for joining us. And yeah, let's launch right into the next slide. So as mentioned, I'm going to talk a little bit about kind of a more comprehensive respiratory virus surveillance now that we are seeing a lot of other things circulating in addition to COVID, and how that's impacting our hospital capacity, a little bit about what we can continue to do as far as prevention and decompression of the healthcare system, and some things that the state has been doing to help respond. Next slide. So just to kind of give a snapshot, and we update this every week on Fridays, you can see the link here on our website, but California is at a high level of flu as far as our statewide status, and you can see the Southern California region is the highest and started earlier. I think when we see this coming week, I anticipate more of the state will be in that high region, and you can see some other sort of snapshot of data that we follow every week related to flu surveillance. Next slide. So what's interesting too is to look at historical seasons. So this is our data looking at hospitalizations, comparing, so 2017-18 is often the hallmark season that we all talk about as one of our last really serious flu seasons, where H3N2 flu A was also circulating. And you can see there that we peaked on, over 6,000 hospital admissions per week. And that was a very high increase, and then actually a fast rise, which was interesting compared to other seasons where things stay a little lower and kind of put along and sometimes like decrease and then increase again. So this year, what is also of note, and I know all of you on the both as just the public and as clinicians are seeing, we are seeing a much earlier flu season than usual. So we saw this increase just much earlier, a very similar trajectory to prior years, and there's some hopeful data here. I'm taking this with a little bit of caution, although now we have a couple weeks now where it looks like the trend is decreasing already. We want to make sure this is not a reporting, sort of underreporting or anything like that, but we are seeing some encouraging signs about this trend. I do think, again, in the state, probably there was earlier activity in Southern California, and now we're seeing more of it in Northern. So there's definitely, again, even within the state, a lot of variability, but some hopeful signs that maybe we've already gotten past our first peak of this very busy flu A season. Next slide. And then RSV, of course, was really causing a lot of stress on our pediatric patients, on infants and toddlers in our pediatric hospitals over the last several weeks. Thankfully, also when we look at percent positivity, this is from our Sentinel laboratories across the state. Again, comparing to prior seasons, we do see we had a much earlier season than usual, and we peaked at a similar level as prior seasons as far as percent positivity. But then we also have seen that peak, and we are seeing a decrease now. So we are thankful that that peak is behind us, and still a lot of activity, but decreasing. Next slide. And then this is just another snapshot. This is actually just Northern California Kaiser, but they do share this data with us, and this is on that website I showed you with our flu and respiratory surveillance every week. I think a couple things to note here, just again, in our kids under 5, you can see this season we had that very early and sharp increase of a kind of combination, really driven by RSV, which is the blue line. And then you can see here now too that now we're seeing flu increase. It's a little hard to see in that lower right-hand corner, but you see a light orange line going up. And then SARS-CoV-2 or COVID is also starting to increase. But the other thing to note is in that background of total admissions, it is much higher than prior years for the last really 5 years. And we're hearing that a little bit in the overall adult space as well, that there are just a lot more admissions for all kinds of things, not just infectious diseases, that are also really stressing our hospitals right now. And of course, you see the quietest sort of COVID admissions within the last couple of years during this pandemic, but a lot more activity just in the last year. Next slide. And then now shifting over to COVID, this is a slightly different visual version of a graphic I've shown you all many in prior months, just a little bit different. But again, the cases are the black line. So we are definitely on an increase again, but you can see compared to our summer kind of surge or swell that it's so far still lower and maybe a slightly less increase of a trajectory, although again, this is reported cases. We'll talk more about ways we look at overall surveillance, not just what's reported. And really importantly, again, back to hospitalizations, the yellow kind of orange line there, you can see we have seen some increases, but definitely lower than last winter during Omicron, for example, and so far is looking a little bit similar to our summer swell. And ICU, thankfully, is still staying relatively low, and our deaths have remained low. Next slide. And then test positivity, another kind of trend, again, we can look at. So even though we know the overall number of tests that we are getting reported to us is much lower than the actual number happening out there with over-the-counter antigen testing, but the percent positivity has been a very helpful trend. It's continued to correlate with trends and hospitalizations over time as well. And so that has been increasing again. So we saw kind of a nadir in late October of, a little bit less than 5%, and now we're up to about 11.7%. So that is increasing as well. You can see the highest we got to during the summer. So we'll continue to follow that closely. Next slide. And then wastewater surveillance. So this is something also that is really helpful because this is not dependent on people's testing behaviors. This is really, again, looking at sewer sheds around the state. And you can see that right now the Bay Area is where we're seeing the strongest increases. Some of you in the Bay Area may have seen some of the local health departments also talking about how some of the levels in some of these sewer sheds are actually higher than during the Omicron peak. So a lot of COVID circulating in the Bay Area, but really throughout the state. And again, we look at this weekly and look at these trends, and this really helps us give us an overall sense and is not dependent on reporting of testing. Next slide. And then another just way to look at a map of what's happening in the state that also drives some of the guidance around masking for COVID specifically. You can see that many of our jurisdictions have actually moved into what the CDC calls the high COVID-19 community level, and about half of our state is in medium. And I think of note with this as well, once counties are out of that low state, that it does mean that in higher risk settings like shelters and incarcerated settings that people do need to wear masks again. And I'll just say briefly that we are encouraging people, because of all of these circulating viruses, not really just dependent on COVID, that now is the time with all of these circulating viruses and before the holidays and all these winter gathering and travel to go ahead and mask again indoors and crowded settings, and really will help protect you and others from all of these viruses. Next slide. So what is the impact on our hospitals? So this is kind of a nice snapshot that now includes both COVID and flu. Historically, I've shown you all a similar slide like this, just focusing on COVID, but you can see now stacked the total hospital census. So to kind of maybe start from the bottom up as far as what you're looking at. So in the lower right-hand corner is our statewide data. So the percent of patients in the hospital with COVID or flu is in the red. So red is showing the percent of COVID. It's around 9% statewide of patients in the hospital. And then about, it's between about 4 to 5% as far as the, I think just under 4% right now for flu in the hospital. And then we're trying, although it's a smaller sliver in there, to show when we do have data on co-infections. And you can see, so historically as well, once we've gotten above 10%, and with those CDC community levels, they look at a couple different parameters. They look at when COVID is over 10% of the inpatient population, and they also look at when new admissions are more than 10 per 100,000 of new admissions. And so in California statewide, we're at about 15 per 100,000 new admissions, and that has been stable for a couple of weeks. We'll have to see what happens when we see new updates, but that's been relatively stable in the last few days. But then when you look at that green line, that is looking at total hospital census, so not dependent on what we've been following over time is how during the pandemic, the percent of patients in the hospital with COVID-19 has often driven the total census. But now we're seeing levels here, California statewide, we're about 21% above a baseline census, which is sort of our lowest levels of hospitalized patients, for example, in the summers or during naders of the pandemic peaks. And we are back to about 21%. So this is similar to what we saw last winter near the Omicron surge times. And you can see, for example, in the Bay Area, they're around 25 to 27% over their baseline census. So hospitals are really stretched. Again, some of these patterns have varied geographically. San Joaquin Valley is also quite stretched at over 20% above their baseline. And again, we're hearing and seeing from this data that it isn't just, unlike prior surges where in the very first winter, we saw over 20% or more of the patients were actually with COVID. We're seeing much more of a mix these days. And we didn't show you a slide today, but we are seeing, of course, a lot of other winter respiratory viruses that are circulating still as well. Next slide. So how does this compare? What are we projecting for the rest of the season? This is a nice, it's still a little busy, but hopefully to highlight some things for you here about how we compare this to prior years, both during the pandemic and actually prior to the pandemic. So we've seen, RSV has led to about 1,000 hospitalizations at a historical peak. And then when you look at sort of flu and pneumonia, seasonally, it can be up to around 8,000. When we had our highest COVID census in the hospital in that first winter of 2020 to 2021, we had over 22,000 people in the hospital at a given time, which really stretched our hospitals the most. So right now, the combined census is around 6,000, a little bit over 6,000. There's a little bit of fluctuation again there in the last couple of weeks with flu and COVID around those numbers. And if you want to kind of look at the graphic here, you can see, for example, our Delta peak last fall in 2021, we had a little bit over, I believe, 8,000 or so in the hospital. This actual y-axis is slightly different than the numbers I'm telling you, but what our projections are, and then a bad 17-18 flu season was much lower than the Delta COVID. We're projecting that the COVID flu combination could be at sort of the most pessimistic projections, maybe somewhere in between the Delta peak from last fall. But continuing to look at that again, there may be some promising signs that maybe flu is slowing down, but we'll be keeping a close eye on that and looking at that. But here, this again provides a little bit of historical perspective and seeing, the difference between that first winter surge, the Omicron surge, and Delta. Next slide. So what else can we do to prevent this? Next slide. So obviously, getting patients vaccinated, getting the bivalent booster, and getting up to date on boosters. We are sadly, still much lower than we would like to be on these numbers for the state right now. We have about 22% of our individuals over 50 have gotten their bivalent booster, and about 37% of those over 65. So that being our highest risk group, we really want to increase those numbers. It's also of note that just this week, actually, the bivalent boosters have been approved for 6 months to 5 years of age, and we have very, very low vaccination rates in that age, even as a baseline. You can see here it's, around less than 10% have even gotten their primary series in that age group. So given the recent hospitalizations with RSV and stretching our pediatric systems, and just knowing, again, this virus really finds our most vulnerable, really need to improve our vaccination for those younger age groups. We do have very encouraging numbers actually for primary series and primary series with at least one booster, especially for our elderly, but now we really need to get people up to date. So hope you all can help continue to get your patients vaccinated and help spread the word that right now it's not too late to get vaccinated before the holidays. Next slide. And then want to spend a bit of time again. I know we talk about this just about every month, but we are really seeing underutilization of COVID treatment as far as Paxlovid or outpatient treatment. We recently sent out a health alert in the last week or so, kind of emphasizing that providers should have a low threshold to treat. And really kind of, it's almost like the default should be to prescribe unless the risk outweighs the benefits. There's no longer a scarcity in supply, and there are definitely benefits regardless of vaccination status. So it's, 85 to 90% prevention of hospitalization in unvaccinated, but even in vaccinated, there is definitely a benefit for decreasing that risk of hospitalization or even prior infection. So it's, and there's some early evidence now that maybe we're even going to have a decreased risk of long COVID for people that get treatment early on. And it makes a little sense physiologically if you're decreasing that viral load, decreasing the impact of the virus on your course. And so again, the things that should not be a reason to withhold treatment include vaccination status, history of prior infection. And I think the other common myth we're hearing a little bit about is if a patient only has mild disease, that maybe they shouldn't get treated. But especially if the patient is over 50, has any other underlying medical conditions, they can absolutely benefit. And we all know that it can start out mild and then get much worse. So early treatment is really the key for COVID-19. And that is true for flu treatment as well. Early treatment is going to be much more impactful. And you don't have to get renal or hepatic function. You don't need to get LFTs before providing Paxlovid or an alternative. So we did send this health alert out. We have a link here. And I'd love to hear later, maybe even if people just want to put in the Q&A or other reasons you all think there are barriers. And we're having a lot of anecdotes of people who are trying to get treatment. We look at some of the websites of some of the large health systems, and they don't really have a process for people to get treatment. Lots of people who are eligible who are getting sort of turned away from their providers. So we really, really want to encourage people because, again, this will decrease the burden on hospitalizations, will decrease the seriousness of COVID-19. So please, please look into this and really make sure you have pathways for test to treat. We do have some test to treat sites across the state that are providing this through telehealth, but really want to make sure that people can get it through their regular providers as well. Next slide. And then just briefly to highlight that the monoclonal antibodies, as we know, often are, as we get new variants and subvariants, are often not effective. And so bebtelovimab, oh, I actually said it, it's always hard to pronounce, but is no longer authorized because of the circulating variants, which are primarily B1.1. And then again, here's the other alternatives here. Next slide. And then finally, just to, and I know again, we'll focus a lot more on this in January. We've been sending out a few different acute all facility letters. We sent one in early November, especially with the pediatric respiratory surge, about different things and making sure, reminding hospitals and facilities what they could do as far as being able to have flexibilities around space and waivers around how they can be creative in treating all the pediatric patients that we've been seeing. Next slide. And kind of thinking about the continuum of care, everything from, I think especially in public health, our goal has been to really do a lot of promotion outreach to the public. So we have some links here to our, 5 tips for winter respiratory virus season, a lot of social media, guidance for caregivers around how to deal with supportive treatment for infection and symptoms. Again, encouraging people to start wearing masks again, staying home when they're sick, washing their hands, all of our common sense things about respiratory hygiene and respiratory etiquette. Also sent something in a few different ways to schools and childcare to make sure they're not requiring RSV testing, not requiring a school note from a physician or healthcare provider to come back to school, because we've been hearing from a lot of you that that's been burdening the system. asking outpatient and urgent cares to have longer hours to help decompress the emergency rooms that have been really overwhelmed. And then other kind of ways that tools in this AFL that talked about making sure people know how and what they can do as far as waivers to expand the space where they can take care of patients. So here are some links to some key resources. And again, we'll talk a little bit more about this next month. Next slide. And I think with that, this is just a snapshot of some of our communication toolkits that are linked on there, but we have some great holiday season social media. It's translated into Spanish and I think some other languages too. So I hope you can all help promote this as well. So thank you very much.
Thanks. Excuse me. Thanks so much, Erica, as always. And thank you to all of you who put that information that she requested into the Q&A. Erica, apparently people are pretty much unanimously saying that interactions with other drugs are the biggest hesitation to prescribing. So interesting, I don't know if you want to quickly comment on that and or maybe some more education around that on a future webinar, and then we'll go ahead and move to the other speakers. But do you want to say something quickly on that?
Yeah, I'll just quickly, that's really helpful. Thank you. I think maybe what we can do is help promulgate more tools about sort of drug interaction tools to make sure that people have that so they can quickly look. But I think there are less drug interactions than people are concerned about. So we'll make sure we try to help get that information out too. But that's really helpful. Thank you so much.
Great. I love the real-time feedback right to the public health system. It's super powerful. So thank you, Erica. Now I would love to introduce Drs. Carol Glazer, Keith Van Haren, and Brittany Martin, who will be giving a group discussion about a fascinating and emerging viral syndrome. So Carol is a pediatric infectious disease doctor who's a medical officer at the state viral labs, and she's run a neurosurveillance project that's known as the California Encephalitis Project for quite a while now. When she started getting calls asking for polio testing, which hadn't happened for many years, she pulled in a pediatric neurology colleague from Stanford, Dr. Keith Van Haren, who's here with us, to help think about these cases. And the team also involved Brittany Martin, who's an epidemiologist at CDPH. The program that these three, Carol and CDPH, along with these colleagues, developed served as a model for CDC's efforts, which didn't begin for another 2 years. So I am incredibly honored to have this team of clinician scientist detectives here to tell us about acute flaccid myelitis today. Thanks.
Hi, thanks, Kim. Can we get the next slide? So in this very brief presentation today, we're going to actually explain to you what acute flaccid myelitis is, and then some of the main clinical features associated with it, and then discuss a few viruses that were really important in causing acute flaccid myelitis. We'll also learn there's many other viruses that can. And in doing so, we'll also explain how to report these cases to the health department. It's very important that you report it. And also explain how you can get great diagnostic testing for a whole repertoire of potential etiologies for AFM at our state lab. And then finally, at the end, we'll just touch on some of the prognosis. Now, Dr. Van Haren recently had a case at Stanford that really serves as a great example and is very typical of many other cases. So I'm going to turn this over to Keith to walk through that case with us. Keith?
Thanks, Carol. So I'll describe a case of a 6-year-old child with acute onset flaccid arm weakness. And this was a previously healthy child. He presented to an emergency room in September with a febrile illness. He was unvaccinated, but he never traveled outside of California, and he didn't have any unusual sick contacts, except for a few household members at home who also had a respiratory illness. In the emergency room, he was diagnosed with an asthma attack. He was started on albuterol and oral steroids and sent home. But 5 days later, he developed a fever to 101 degrees. He had sudden onset of pain and weakness in the left arm, which was actually very acute. That prompted a return to the emergency room. And his exam was notable for him being an alert, conversant child. His exam was normal neurologically, except for complete flaccid paralysis in the left arm with absent reflexes but preserved sensation. So the clinicians on the front line very astutely admitted him to the intensive care unit due to concern for impending respiratory failure. Next slide. So The reason the clinicians on the front line were so concerned is they had a sense of his motor neuron activity, and this is an overview of the motor tracks in the brain. So starting at the top, you have the upper motor neuron beginning in the motor cortex, with the axon winding its way all the way down through the brain, brainstem, and spinal cord, and synapsing closer to the bottom at that red dot at the lower motor neuron. And the lower motor neuron runs out through the motor nerve to the neuromuscular junction and innervates the muscle itself. So lesions of the upper motor neuron produce spastic weakness, and then lesions at the red dot or distal to that, which constitute the lower motor neuron, produce flaccid weakness. And this is a really helpful delineator for neurologists and frontline clinicians to distinguish between upper and lower motor neuron signs, and that's muscle tone and weakness. So next slide. This finding helped the clinicians zero in on the right test order. They zeroed in on a spinal MRI, which revealed longitudinally extensive injury to the anterior horn cells, or the anterior motor neuron horn cells in the spinal tract. This was suggestive of a primary motor neuron injury, primary lower motor neuron injury, I should say. And the spinal fluid revealed elevated white blood cell count. So the white blood cell count was 34, where normal is less than 5. So this suggested an inflammatory process at work. The brain MRI was normal, and the remaining labs were unremarkable, with a log antibody pending. Next slide. So the larger diagnostic category here is acute flaccid paralysis. This is a large diagnostic group that includes a variety of diagnostic categories, but it does localize to the lower motor neuron unit, as shown in the box in the upper right. And so this includes the motor neuron itself, as well as the motor, the axons and the muscle and the neuromuscular junction. So within acute flaccid paralysis, that includes Guillain-Barré syndrome, which is pathology of the motor nerve, as well as myasthenia gravis and botulism, which affect the neuromuscular junction. And then acute flaccid myelitis is direct injury to the motor neuron body itself. Next slide. And this is kind of just a zoom in on the motor neuron area itself that would be injured in acute flaccid myelitis. And the viruses that can cause this would include West Nile virus, Japanese encephalitis virus, and most commonly, currently, enteroviruses, and historically, polio virus. Next slide. So the workup continued for this child. He received IVIG, steroids, and Plex. His MOG antibody came back negative, and he proceeded with an extensive ID workup. But I'll credit the frontline clinicians here for very quickly notifying the public health department because of their concern for this flaccid paralysis syndrome. And they did a terrific job in connecting with the public health department. I'm going to pass it back to Carol to provide a little more background here.
Sure. Next slide. So actually, the way this case came in directly to us was that the clinician had contacted the local health department, who then called us because they were suspecting polio. And, you know, this may seem like really way out there, right, in this day and age that anybody would be talking about polio. But as we'll see in a few minutes, this was not so far out. Next slide. So, you know, it was over 5 decades ago that, you know, polio, we really saw a lot of polio, and I'm guessing that the vast majority of us on our call have never seen it. But I do think it's important to recall that at that time, polio was probably one of the most, if not the most, feared disease on the planet. You know, parents were told not to let their children play with other children, not to let their kids go to a swimming pool. Little league games were canceled. It was really virtually every parent's worst nightmare that their child could come down with polio. Next slide. And polio, just a real quick primer on it. It's a type of an enterovirus, and when we think about entero, we often do it very simplistically, where we sort of lump them into is it a poliovirus entero or is it a non-polio enterovirus? Of the polio, there's 3 of wild types, 1, 2, and 3. And like other enteroviruses, they're often fairly infectious. But the good news is most people that become infected don't have any symptoms or are fairly mild. It's less than 1% of infections that will ever lead to paralysis, although when you get a lot of infections out there, that will really affect the population. And indeed, in the early 1950s, about 15,000 cases of paralytic polio were reported every single year in the United States. Now, in 1955, a very effective vaccine was introduced and widely used. And this is one of the best vaccine success stories. It resulted in this plummeting, as you can see on that graph on the lower bottom, cases just absolutely plummeted. This was such great news. This was such a relief to so many families and parents who really, truly worried about, their child being paralyzed. And the vaccine has been so successful that right now there's only 2 countries in the world that have any polio, and it's the polio type 1, and that's in Pakistan and Afghanistan. However, we have a little caveat here. There's about 250 cases that are occurring now each year in about 30 countries of what's called vaccine-derived polio. This is a very complicated issue, sort of deserves a whole grand rounds on itself, but basically it's a situation where the oral polio vaccine circulates in a community, largely an under-immunized community, and sort of mutates, and over time then it gets into the right host and it can cause paralytic polio. And indeed, what happened this past summer was that an individual in New York, previously perfectly healthy, but totally unimmunized for polio, he acquired the infection and he became paralyzed, and presumably he will stay paralyzed for life. And so this is something that we really have to be thinking about. New York recognized that if you just have a single case of paralytic polio, there's got to be other cases out there, because as I mentioned, less than 1% will turn into paralysis. So they use their wastewater COVID program that Erica just talked about, the way we use wastewater and detect COVID. They use that same system and they started to look for polio, and indeed they found it. So that at least in the New York area in the United States right now, they did find that. So what was a virus that we never really had to think about, we really have to start thinking. So it's very appropriate in this setting that the physician was thinking about polio, as Keith outlined, that individual had been unvaccinated. And this is going to be something that we need to start thinking about. Next slide. So as it turns out, it did not turn out to be polio, although it was an excellent thought on the part of the clinicians. We ended up finding a different enterovirus, and that was Enterovirus D68. Next slide. So about Enterovirus D68, in case you've never heard of this virus, it groups into that one of those non-polio enteroviruses, and it's specifically in that non-polio entero group. There's 4 groups, and it falls into group D, not surprising as its name. And it tends to cycle every 2 to 3 years. And this virus was very much considered an obscure virus. When Keith and I were working on this a couple years ago, before the huge 2014 outbreak, we were told this is an obscure virus. It can't be doing what we think it might be doing. And it was really just a footnote in many, many books. But in 2014, there was a very large, really unprecedented outbreak of respiratory illnesses by an enterovirus. It was literally sending thousands of children to the emergency room, primarily with respiratory related issues such as asthma exacerbation. This was very much what we called an explosive epidemic. So this in itself was enough of a crisis. But then, next slide, just on the heels of this, there was basically an epidemic of flaccid paralysis. So it was a much smaller, but a devastating epidemic that was in very close association with Enterovirus D68. At that time, there was a lot of discussion about what to call this. Would we call it a polio-like myelitis? In fact, that was a term that we often use. But basically it was decided to use the term acute flaccid myelitis. This is a relatively newly coined term. It's not a new phenomenon, but the term itself is now, that's what the term we use when we talk about this. And despite this very tight clustering of those acute flaccid myelitis cases to the NROD68 respiratory outbreak, there was, by the time the kids had the paralysis, we often couldn't find the virus, and we never found it in the spinal fluid. And when Brittany's in a minute going to talk about specimens, it's important to realize that spinal fluid is not necessarily where you're going to find this virus. Importantly, also in the background of this whole epidemic of the D68 causing the flaccid paralysis, we were also seeing a smaller but significant group of kids that had yet another enterovirus called Enterovirus A71 from the group A that was also causing a paralysis. So, this is a lot of information. And the most importantly thing about the A71 was that the prognosis in those cases tended to be much better than D68. At the end, Keith will talk about what happened with his case, and unfortunately is true on many of these other cases, but the A71 has a pretty good prognosis. Next slide. So because of this large epidemic, CDC stood up a surveillance very quickly, and Brittany's going to walk us through what that surveillance system looks like. Brittany?
Thanks, Dr. Glazer. So yeah, a little bit on the epidemiology of AFM in the United States. As of December 1st, 2022, there have been 709 confirmed cases of AFM since CDC began tracking this in August of 2014. As you can see in the epi curve, most patients developed AFM in late summer and early fall, with cyclical peaks every 2 years in 2014, 2016, and 2018. During surges in AFM before the COVID-19 pandemic, Enterovirus D68 was the most common enterovirus detected among AFM cases. And an AFM increase in 2020 and 2022 did not occur as would be expected, presumably due to COVID-19 mandates and precautions. As of December 1st of this year, there have been 30 confirmed cases in 18 states. Although more than 90% of confirmed AFM cases have been in young children, it's important to note that cases have also been confirmed in adults. And for this reason, adult infectious disease clinicians should also keep AFM in mind when they see a patient with acute flaccid weakness. Next slide. So moving on to AFM in California, we also saw increased activity in 2014, 2016, and 2018, similar to the AFM peaks nationwide. California mirrored the nation's low AFM activity from 2020 through 2022, again, presumably due to COVID-19. We've had 8 cases in California so far in this year. And in addition, in late summer of this year until now, EVD68 respiratory disease has been detected at sentinel surveillance sites. However, unexpectedly, we have not seen a corresponding increase in AFM, and reasons for this are not known. Next slide. So on to reporting. This reporting of suspected AFM, which would also be the same as reporting a suspected paralytic polio case, as was done in Dr. Van Heren's patient, and the astute clinician reported this acute flaccid weakness. It should be reported in any age promptly to local public health. And for AFM in particular, an MRI showing spinal lesion and gray matter is needed. However, do not delay reporting if awaiting MRI results or MRI results are unclear. After suspect cases reported, relevant specimens should also be collected and routine AFM investigation begins, which includes assessing risk factors for polio, like travel and vaccination status. CDPH also offers clinical consultation as well and a team to help with reporting. The local health department will work with the clinician to compile information and send laboratory specimens to CDPH's state viral lab. And the state viral lab will test specimens, and a neurology panel at CDC will review clinical data and provide an official AFM surveillance case classification. Next slide. Next, we'll go through the testing algorithm for AFM specimens. Specimens should be collected as early as possible, preferably on the day of onset of limb weakness, to maximize the chance that a pathogen is found. The specimens to collect include a nasopharyngeal and oropharyngeal swab, CSF, serum, and 2 stool specimens at least 24 hours apart, and those should be shipped to the CDPH viral lab. Testing should continue at the hospital laboratory for specific pathogens as clinically indicated. Specimens will go through molecular and serologic tests at the state lab and specialized testing at UCSF labs. This algorithm and collaboration with the CDC will identify polio virus in stool if present. So getting stool is very important. The clinician in Dr. Van Heren's situation did an excellent job of sending the right samples for testing and investigating differentials. In the testing, as Dr. Glazer revealed the presence, as she talked about, revealed the presence of EVD68 in the respiratory specimens. Next slide. So fortunately, AFM and polio are still rare. However, since they're so rare, why do we care? And so back to Dr. Van Heren.
Yeah, thanks, Brittany. So perhaps the most important reason to recognize and triage these cases is that they really do represent a neurologic emergency, typically in children, but not always. And the reason they're a neurologic emergency is that individuals with acute flaccid paralysis can develop acute respiratory failure. This is true of most cases of acute flaccid paralysis, whether it's due to acute flaccid myelitis, Guillain-Barré syndrome, botulism. But recognizing it as part of that constellation is key. The cases are also not always straightforward. There are a variety of potential mimics here. Other features or other diagnostic categories that can present with similar aspects of acute flaccid paralysis would include stroke in some cases. There is an autoimmune condition that's more and more recognized called MOG antibody syndrome. And there are some other autoimmune syndromes that can present with similar features. All of them can present with acute flaccid paralysis. And what is key here is at the time of reporting, you don't need to distinguish which is which. You're essentially identifying a case of suspected acute flaccid myelitis or botulism otherwise. And that's the point at which you want to report. So very early, as early as you can. This is primarily a condition that has been affecting children historically, both in the polio era and now. But there are cases that can affect adults as well, including West Nile virus. And of course, given the global situation with polio's potential reemergence, where it's important to also be clued in for cases of possible polio reemerging in clinical cases. Next slide. So in the case of our patient, I saw the patient in follow-up in ensuing months. And as is typical of most individuals affected by EV68, the recovery was very poor. There was minimal motor recovery in the arm and hand. This prompted a referral to our neurosurgery and plastic surgery colleagues here at Stanford for a nerve transfer surgery. This was pioneered in brachial plexus injuries such as Erb's palsy associated with a birth injury. And this has had some success in a few cases of acute flaccid myelitis. It is worth considering in other patients, but in this case, it didn't really have much of an effect in the child. Here, the left arm that was completely flaccid at the shoulder and elbow, but there was some improved hand strength following the nerve transfer surgery. But despite the weakness in the arm, the child really recovered very well socially and was not set back in school, in social activities, and even in sports, and resumed his usual activities at almost his previous level. He remains engaged with occupational therapy services and continues to follow up now. I think I'll let Carol wrap up the slides from here. We'll go to the next slide.
Yeah, so just a couple quick take-home points. Yes, this is rare. Hopefully you won't see a case, but really is incredibly important to recognize and to report it and to test early and with a very thorough battery of specimens. If people think, oh, spinal fluid is such a great way of diagnosing these neurologic conditions, and in this case, really poor. So we really need you to think about it early on, report it, and get a full complement set of specimens. And, you know, I think just for future, we really don't understand the risk factors. This is, you know, something we'd love to understand better so we could give better prevention messages. And we certainly, even though there is the nerve transfer option that Keith mentioned, it's not good enough. We need to figure out better antivirals, particularly for enteros in general. So we're hoping that, you know, there's all these candidates out there for antivirals for enteros, but nothing's really, you know, on the market yet. And that's all I have. Thank you. And thank you so much for letting us present this important syndrome.
Well, thanks to you all for this incredibly interesting and important story. And, you know, these very rare things, it's important that we all hear about them because otherwise we just won't know how to manage them. So I'm really happy to have you here. I have a few questions and then for your team. But first, I just want to take a moment to acknowledge that Carol was here a number of months ago telling us about this really exciting canine COVID-19 program. And so I just asked her to give one brief update on how that program's going. So thanks.
Yeah, and Kim did stress brief because she knew I could go on an hour, but and this is definitely a much happier note than the presentation we just gave. So basically, we're now in what we call phase 3 of this program. The phase 1 was where we work with trainers who taught the dogs to be able to detect the scent of COVID. And it's not the virus itself they're detecting the volatile organic compounds. So we got a bunch of people that had COVID give us socks, and then these dogs were trained with a training wheel. And then the phase 2 was when we took them out to schools and we compared how the dogs did versus how they did with the antigen test, and that lineup of the kids, that's the dogs running that line, and then they sit if they see a positive. They did pretty good in schools. The sensitivity of being able to detect it wasn't quite as good as in the initial scent wheels with the socks, but okay. We're now kind of back in the lab with them, retraining them because we don't know if the variants have changed a little bit, the VOCs. But what I'm looking for and I'm interested in is we're actually expanding beyond schools. If people would like us to bring the dogs, it has to be in the Bay Area. And I'll maybe if somebody can put my email in the chat, if you think you have a venue like a nursing home or an area, I can talk to you more about bringing those dogs in. So we still have some work to do. They're not quite at the sensitivity that we want them to be, but definitely it's going well. And you know, the schools and the kids, not surprisingly, absolutely loved it. So you know, what we're really doing is trying to think about even beyond COVID, if we ever get beyond COVID, you know, could they be used for a lot of other things? So thanks, Kim, but for letting me talk about that. But it's a very exciting program.
Yeah, super exciting. A couple of questions for your team, and then hopefully we'll have Erica pop back on because we had some questions from the audience for her as well. But one question back to acute flaccid myelitis is, and I know the numbers are so slow, but between that and also the severe respiratory illness, are you seeing any patterns in ethnic or racial differences in the manifestation of these conditions?
I can take that one. You know, in California, the race and ethnicity proportions for confirmed cases from 2012 to present, so about 10 years, generally matched the US Census proportions in the state. So no major differences are being seen right now among races and ethnicities.
I do want to just add real quickly to that. Both Keith and I worked with Dr. Miranda Kane from Kaiser, who looked at AFM in a population-based setting. and it had a lot of limitations, but we did see a higher signal for the Asians than we would have expected based on their population. So we don't really know what that means. Something that I'm always kind of looking at. We know there's other neurologic conditions, but like flu encephalopathy is seen more commonly in the Asian population than it is in a lot of the other groups. So something we're keeping an eye on. We certainly are not making any profound statements, but very interesting observation from Dr. Miranda Kane. That was published in the Peds Infectious Disease Society journal about 2 years ago, I think. I don't know if Keith remembers. We both worked on that with her. So
yeah, great. Thank you for that. And then one more for your team for now. We'll keep going back and forth, but people are wondering a lot about who needs a polio vaccine. So can you sort of direct us about, folks who were immunized decades ago in their 70s and 80s, do they need to go in and get a polio vaccine? Or, where's the best place to get the information on who needs boosters for polio?
Sure, I can take that one. So at this time, polio boosters are not recommended for travel within the United States. Adults who completed the polio vaccine series as children in the US and are planning to travel to countries with increased risk of polio or have a higher risk for exposure to polio are recommended to receive one lifetime booster dose. If someone is going to travel internationally, they should also check with their healthcare provider about getting a polio vaccine booster.
Okay, great, thanks. Erica, I'll just switch to you for a couple of questions. One of which is, speaking of emerging viruses, not really emerging, but ones we don't see that often, do you want to comment a little bit on what's happening with measles in our country right now?
Yeah, unfortunately, I mean, and just to sort of talking about vaccine preventable diseases like polio, we are seeing, gaps and lower vaccination rates in general across the country and in pockets of California as well. And in Ohio, there's a large outbreak happening right now in a largely unvaccinated population. And interestingly, a large proportion are sort of larger than normal are being hospitalized. A lot of it's from dehydration or other things, but I believe the number I heard yesterday was around 30% of the ones reported to them, and they're wondering actually if there's some milder cases maybe that are not reported in some of their unvaccinated teens, for example, that might be transmitting to others. But hugely a definite sort of increase. And I'd say also that there are more and more measles outbreaks around the world right now, I think much higher than we've seen. So I think unfortunately that is something that we are going to see more of, and just want to encourage people again to get their patients and their families up to date on their vaccines. Many of us remember, and Carol and I were reminiscing about the Disneyland measles outbreak, and we were very involved in that many years ago, and really don't want to see that again in California, but a lot of concerns about that.
Great, thanks for that update. And on another virus, we didn't hear much this time, and I think it's because of the steep decline about MPX. Do you want to just tell, is there any news about that, or just give us an overview about how it's going? And just curious if you have a hypothesis about the steep decline, how we got out of that relatively quickly.
Yeah, thanks. And happy to, again, circle back on that again in the future too. Sorry, we didn't cover that. There's, because of the more emergent strain on our hospitals, focused on that. But yeah, MPX, thankfully, we've really dramatically seen a dramatic decrease nationwide, and here in California, we're down to about, 2 cases a day in our big state. I think, yeah, there's a lot of discussion happening. We were on some calls earlier today about this. Is it a combination of we have increased vaccination, getting the JYNNEOS vaccine out, especially in the high risk populations? There were some behavior changes, certainly in certain populations as well. And or, again, of course, like other things, is there some prevention of future infection from people who are already exposed? I think there's some increasing concerns about pre-symptomatic infection and transmission. So I think that's something we're keeping an eye on, but increasing kind of data with concerns about that. But in general, yes, we're seeing a good decrease in that. The federal state of emergency will be winding down. We still want to make sure in California that we are keeping our eye on that, and also just continue to attend to equity. So we've seen a lot of disparities in vaccination, and really trying to work on some of those equity issues, including, I guess, two quick things I'll mention is making sure people do realize that there's much more flexibility now about subcutaneous versus intradermal administration, because, you know, when we were really worried about scarce supply, we wanted to really stretch out and use those intradermal doses, but we do know that that has been a barrier and an equity barrier, actually, a lot of people with concerns about scarring or stigmatization with that. So very flexible on subcutaneous, and really everyone who, we really don't want providers to turn anyone away who's interested in getting JYNNEOS vaccine for MPX to prevent that. So there's really broad eligibility now. Again, it's different because we have more supply than demand now, and we certainly have priority populations that we're really leaning into, but again, there's no restrictions on eligibility, so we want people to be very liberal with doing those vaccines.
Great, thank you for that update. One question for really any of you, I guess, is people are wondering about polio, and I think we talked about potentially doing a deeper conversation about polio, but what's the thought about whether it's going to spread? What's the risk for that? You know, it's again, I always ask Erica a crystal ball, so I'll throw a crystal ball to the rest of you today too. I know you can't fully look into the future, but thoughts, what are your thoughts, guesses?
I can take it. I think so there are a few things needed for a polio case or polio cases. One, a patient with travel to or from an area with poliovirus. Another is a lapse in hygiene permitting fecal oral spread. And then the third is vulnerable contacts, so someone not immune or vaccinated. And so currently high levels of immunization and high standards of hygiene greatly minimize the risk. So while it's possible that polio can be or has been introduced periodically through international travel, high levels of routine immunization against polio in California help keep the risk of paralytic polio cases low. Again, just as a reminder, the region where the polio case occurred in New York has low immunization rates, and a case was unvaccinated against polio.
And to add, actually, Brittany, that they were really low. I think I read as low as 37%. As far was that is how low it was in Rockland County, which is where that case occurred. Although, you know, California, you know, we're experiencing those lower, not that low, but you know, certainly during the COVID era, you know, we're those rates are dropping. So, you know, people don't think about polio as a real phenomenon anymore, and they may want to just skip that vaccine, but it's really important. I mean, we're so spoiled. People don't know what real polio looks like. Most people don't even know what real measles looks like because the vaccines were so effective. But, you know, as soon as we let our guard up, we start seeing these cases again. So.
Yeah, so important to remember that. We unfortunately only have time for probably one more question, which I'll send to you, Erica. People are wondering about any updates on variants of concern and specifically the effectiveness of our current boosters and the therapeutics that you were talking about on variants that are currently circulating.
Yeah, sorry, I didn't include a slide today on that, but what's one exciting update, and I can snapshot that next time, is we have a nowcast that is California specific of our variants. It's at CalCat, if you just sort of Google CalCat, but we have now added not only flu modeling and projections to our CalCat website, but also our variant nowcast. Because whole genome sequencing certainly has a big time lapse, we kind of do what the CDC does as well, but for California specifically to look at what we think is circulating. So largely we are seeing these subvariants that we're seeing nationally that are, again, the BQ 1.1 and BQs, but there's nothing on the horizon that we've heard about that we're super concerned about. This is certainly immune evasive as far as, again, infections as we're seeing. Thankfully, we think prior infection and vaccinations are holding up pretty well for hospitalizations and serious illness as well. But again, of course, like with other things, that are most vulnerable are the most, you know, susceptible to still getting more seriously ill. And then we already mentioned the monoclonal antibody, which in general, I think because of the spike protein dependence of the monoclonal antibodies because we're seeing the most variability with these new variants, that's really, but the Paxlovid and other antivirals that are oral have a different mechanism of action that are not as susceptible to all these changes in variants.
Great. Well, thank you. Lots of questions as usual we can't address, but I just want to really thank you all for being here today, the DREAM team, and for doing this work on acute flaccid myelitis, and Erica, as always, for showing up and educating us. Our next session will be on Tuesday, January the 10th, and as I mentioned, Dr. Michael Vollmer will give us a presentation on this incredible surge of respiratory infections and really tell the story about what's happening in hospitals and clinics around the state this fall and winter from RSV, flu, and COVID. So please do sign up for that, covidroundsca.com. And just remember, if you want CME to fill out your survey. Our whole team here, who I'm always grateful for in the back end, would like to wish you and yours a very, very happy and very healthy holiday season. Please mask, as Dr. Pond said, if you can. Thank you, everyone.
Thank you.
Thank you. Happy holidays.